two things, our primary care physicians being aggressive about it, and then the phase program that Pat mentioned, which is preventing heart attack and stroke every day. So certain individuals are automatically identified as being higher risk and plugged into this program, and they get additional counseling and a little more specific treatment. So I think it's certainly doable, but it's, you know, it's not necessarily simple.
Can I make one?
How do you define that practice? You're saying to have a better, is it the outcome? Is it, are you talking about door to needle? What exactly are you talking about?
He's talking about the blood pressure control numbers that are in your, in the last page of your bios, you'll see the blood pressure performance bar charts.
Okay.
And I just, oh, did you want to go on, Dr. Hartman?
I'm done.
And Dr. Ivy showed those slides earlier in the presentation.
I would like to add, I think that listening from Kaiser, I think it really shows the benefit of an integrated system. So our patients are not lost to follow-up, they get professionally nagged. You know, if they go in for their mammogram, they get asked, have you had your flu shot? The Northwest region is talking about extending that to their dental offices. So, you know, anyway, that, I think that's the bottom line. It's really having one system that follows the patients through a lifetime. Amen.
Can I?
Dr. Ng, and then I think we're probably going to have to closely wrap it because we are now at the top of the hour. I'll just make one brief announcement after you, Dr. Ng.
Sure. I just wanted to mention one thing is that when we think about like healthcare in general and like managing like secondary prevention of diseases, like a major issue that comes up, especially in areas such as California and Sacramento in particular, is the diversity of people in that area. Like being able to relate to like different ethnic groups and be able to relate to them in the same way is actually it's a challenge. And when we think about prevention of disease, especially hypertension, understanding that relationship to one ethnic group versus another ethnic group is something that, like, as a provider, like, that you sees everything that comes through the door, excuse me, is that, like, it is something that, like, we all kind of have to work really, really hard at in terms of being able to provide the same level of care, whether you're from this group or that group, knowing that their level of education, their level of ethnic understanding of what that disease is really, really varies. So in, you know, just as just the last standing statement is that, like, in order to really understand and actually provide better care for those patients, we really have to understand those patients better.
So I would like to see how the data was collected. Was it matched with the socioeconomic strata? You're comparing Santa Clara with Sacramento County, and I would say the stroke, the belt of the stroke, it's further south. I worked in San Joaquin Valley, and the situation is well different. I would like to see if you match those socioeconomic extracts with what we have here, because it's a what
Believe
Dr.
it or
is trying
not,
to say.
we really don't have the capacity to do that, but
So-
we do know that we have a much higher incidence of stroke here and a much higher death rate from stroke here. That's not risk adjusted, but it's real. And so we have a big cause here. And in terms of can the Kaiser approach be applied broader community-wide, I should say that in San Diego, the first community where we started this, that's exactly what we did. We used the phase program, which is prevent heart attacks and strokes every day, which deploys the ALL protocol, now the TAL protocol, thiazide, aspirin, lisinopril, lipid-lowering agent, and saw heart attacks plummet relative to the state, but not strokes. Strokes are a little harder. And so I would just like to ask you all to come back. Second Monday every month we meet here, and the leader of our San Diego program, Dr. Anthony DeMaria, the longtime editor-in-chief of the Journal of the American College of Cardiology, will be here with us, and he can talk about how they have implemented a more community-based approach to getting all patients screened, because of course, if you don't screen them for blood pressure, they don't know, and then appropriately treated from a prevention standpoint. And I'm happy to stay and talk as long as people want to talk, but I know that we're a bit over time now.
Thank you, Dolores.
Thank you for coming, and buckle up your seatbelts on the way out.